Hello, everyone. I would like to introduce myself. My name is Christopher Mambula. I am a desk manager or program manager with Médecins Sans Frontières France, based here in Paris, and I will be moderating. I will be moderating the today's webinar. And what we can do is we will have a session. So the way it's being organized today is that we will have 3 presentations, and then followed by questions and responses, and then another, participants, I can say people who are also able to give their own life experience will also share, and we will be able to have quick discussions around that. Each participant or each presenter will have approximately 10 minutes to present, and then of course you can pose your questions as well. So just as a reminder, this webinar is actually co-organized by MSF's HIV working group. So basically, Médecins Sans Frontières, we have a working group where we actually have specialists who have been looking at different aspects of HIV care over the years, and they come together to talk about policy, to talk about things that are strategic in terms of moving the HIV management forward. And we have Epicentre as well, who is in fact co-hosting and co-organizing this webinar. This is the first of 3 webinars. It's a series of 3 webinars. And we're talking about the historic commitment of MSF to HIV, and of course the challenges that we're facing in disease management. So we will be focusing on the priorities of MSF, focusing on HIV. What we've talked about, I think, in the last few years. One is prevention. So we're talking about what are the new changes and what are the new things that we see in prevention. We talk about neglected populations, including children and people who are failing on different treatment regimens. And what is patient-centeredness or people-centeredness? Because in fact, behind all of what we do is actually people, it's patients, it's people who are living with HIV and are having to live their lives, but at the same time, stay healthy. And of course, how does the environment where we work, so where we find ourselves, how does that impact or how does that affect the way we treat our patients and the way our patients are able to access care in a way that is favorable to them. So we will try to share from these different experiences. So not to take too much time, I will introduce the first speaker. Her name is Jihane, and she is an epidemiologist with Epicentre. She has been working on HIV a lot in East Africa, and she has been coordinating numerous evaluations on models of care and being able to provide what I would call facilitating options for a differentiated model. So Jihane, without much ado, I will give you the floor and you can start your presentation.
Thank you very much, Christopher. I'm going to switch to French. Bonjour à toutes et à tous. Merci pour l'introduction.
Hello, everyone. Thank you, Christopher, for the introduction. Indeed, I'm epidemiologist for Epicentre and MSF. My presentation that is about 2 models of differentiated care.
Merci. Donc, comme je vous disais, je vais vous présenter.
Thank you. So, as I was saying, I will present the evaluation of various DSDM in Goma, DRC, and Kasese in Uganda. To give you some context about the HIV situation worldwide, at the moment, the number of people living with HIV is above 38 million people, of which 20,000 million in Sub-Saharan Africa. Since 2010, the WHO suggested various strategies to eradicate this pandemic. So they introduced the strategy 1990 that I will not present nowadays together with UNAIDS. And this was a strategy to eradicate these pandemics. In 2010, the approach was to treat any people who had HIV, and in 2015, 16, it was to use the DSDM that I will introduce now today. This differentiated services delivery is an approach that simplifies and adapts HIV services to the preferences and needs of people living with HIV. Now we are focusing on care, patient-centered care. So I will introduce this package to you, but within the all aspects of HIV care, there is the people living with HIV at the center. So there are various services, lab testing, advices, support, and we will ask this specific person her expectations, her preferences to adapt our approach and the care we will be offering to this person. These approaches enable to reallocate resources to prioritize those who need it most. As I was saying, these are different kinds of models. I will introduce today the most renowned and most implemented model, which is the differentiated antiretroviral therapy delivery, which is a very specific type of care, and it will impact the viral load as well as the person adherence to the treatment. So to do so, I will introduce the French experience in an urban area and then in a rural area. So the first one in an urban area in Goma, DRC. To give more context at the national level, HIV prevalence is 1.2%. The country very quickly implemented this integration and decentralization and integration of HIV activities into all health services at the national level. And in 2016, they implemented the test and treat strategy that I will introduce. In 2018, they developed an operational plan for the provision of differentiated services. Today, we will be talking about Goma in North Kivu. How does the MSF integrate in Goma in taking care of the patient? MSF collaborated with the Ministry of Health to improve the quality of people living with HIV, and in March 2021, they offered their support to the Ministry of Health in implementing community ART groups. So I will now present this that are part of the treatment delivery. When a patient is considered as stable, clinically stable, they have different options for their treatment. Either every 3 months, a person with HIV that is stable can have their treatment every 3 months. So they can either continue their usual treatment that they've been following up for the past years, or they are offered the opportunity to integrate a community group of people living with HIV, and one dedicated person will go get all the treatments for this group. We evaluated these services for over a year, and the objective was to evaluate the model by measuring indicators of the continuum of care, as well as the satisfaction of people living with HIV. So I will present now the outcomes of this evaluation. So for the first results, we assessed the retention and care at 12 months of this person with a Kaplan-Meier analysis. So at the top, you can see the curve of the trend of people who are still in care. So at 6 months, and at 15 months, 96%. So we are above the retention in care that we had previous to the implementation of this new delivery model. We also ask these patients to fill in a questionnaire about their satisfaction on key aspects of the community group, such as exchanges with other members, confidentiality within the group, mutual support, renewing of their treatment, the follow-up of their viral load, as well as the organization of the group. As you can see, a large portion of the group is quite visual here. A large majority of this cohort were satisfied or very satisfied of this community group. Now in Kasese, a rural area in Uganda, we also implemented this kind of model. So I'll give you a brief context of this, the HIV situation in this country. HIV prevalence, Uganda is one of the countries that is the most burdened by this, but they reached 90 a few years ago, and very quickly, to reduce the number of patients in the health infrastructure, they wanted to implement new strategies to offer care to the people who most needed it. So in 2016, they implemented the test and treat policy nationwide, and they also deployed the differentiated services delivery models. And we have been working in the south part of the country in Kasese. So what is MSF role in this? MSF, together with the Ministry of Health, delivered high-quality HIV care to fishing communities. After an anthropology study, we noted that the nomad life of these communities was a major obstacle for these people to get access to their treatment, which is a key indicator for good care. So that's why MSF in 2016 supported the ministry. So there were different strategies that were deployed by the Ministry of Health. MSF supported the Ministry of Health in two specific strategies. The first one, fast-track drug refill. So we are offering to a stable patient to still get their treatment at the clinic, at the care center, but they have some sort of quicker fast-tracking entry, so they can get their treatment faster. And the second one is the community client deliver. Our objective was to compare the characteristics of, to evaluate these two models, to compare characteristics of clients choosing FTDR and CCLAD, describing the outcomes of retention in care, viral load coverage, and viral suppression that are key indicators. So I will present you two outcomes at 12 months. So the first result is the retention in care at 12 months. So for Congo, the numbers were for 6 months, but at 12 months, 97% of the people who choose the community model were still retained in care, and for the FTDR it was 91%. So we are still higher than the number of retention for people who have been following the usual treatment model. We also evaluated the patient satisfaction for people who choose the community model. We had a very positive perception from client and provider because of the convenience, the lower transport costs for treatment access, the minimizing waiting time. And I read now the verbatim of a male patient who chose the community group model. and it summarized what we note with this evaluation. I like this initiative so much that even when I'm absent, I am able to receive my drugs. And another thing is that when I'm busy in my business of fish buying and selling, they still bring my drugs to my home. That is why I like the group. And for the patient who choose the FTDR, we measured a high level of satisfaction in the quality of care and also the contact that was maintained with the care professionals, staff. This person said, I have no problem in the way I get ART services because on arrival at the facility, it does not matter whether it's a Thursday or Saturday, we can refill on Tuesdays and sometimes on Wednesday and Friday. We who get ART services, they treat us very well. There is no one you will find complaining on the ART services from here in any observation. It was a female patient. To conclude, other significant progress were made, and the approach we use is not adopted anymore. The results of this evaluation underline that this kind of model ensure a high level of retention, especially for mobile communities. So differentiated services, especially community groups, were accepted by HIV positive patients when they were introduced by MSFs in these two contexts. I also want to warmly thank Dr. Frank Lutu and Dr. Carol Liu, who manage these assessment evaluations on the ground, as well as the coordination teams, and you for your attention. Thank you.
So the next topic or presentation will be made by Paula Cuenca Ruiz, and she will be presenting integration into chronic disease care in Malakal in South Sudan. So it's HIV, TB, hepatitis C care in Malakal, and examples of strategies for follow-up and management of people living with HIV and feedback. Paula is an internal medicine and infectious disease specialist with a long history of management and follow-up of patients with HIV, TB, and hepatitis, and has been with MSF since 2018 and working in different contexts, such as in Colombia, in India, in some sub-Saharan African countries like Central African Republic and South Sudan. She's involved in a chronic care unit project since 2021 and is developing materials and protocols that make up the toolkit, which supports the different work that MSF does on the field. And she's currently working as a HIV, TB, hepatitis referent for MSF Spain and continues to support the chronic care unit activities. So over to you, Paula.
Thank you. Thank you so much for the introduction. So let's start directly with the chronic care unit, or also called CCU. What is the chronic care unit? Okay. So the chronic care unit is a people-centered unit that aims to optimize chronic care, decrease morbidity and mortality, and improve the quality of life and the quality of care of the patients. Among other objectives, we have reduce stigma, adjust service delivery to people's needs, increase adherence to chronic care, and reinforce self-care. We say patients with chronic conditions often have multiple comorbidities. Having one condition increases the risk to get another one, and it happens, we know, with people, for example, with HIV and TB, the diabetes and TB, HIV and depression, and also tuberculosis, for example, and chronic bronchitis. So also the presence of depression has a negative effect or impact in the adherence to the chronic treatment. So this is an integrative and collaborative model of care that seeks for the integration and the management of chronic disease in MSF project. It's not happening. It's not continue the presentation. You cannot see the next slide, no?
No, we cannot.
I don't know why it's not. Before it was working. Okay. So, any tip to make it work?
Is it being controlled by yourself? Or...
Yeah.
Okay. And you've put it in presentation mode?
Yeah.
Well, then maybe you might need to come out. It'll be much smaller, unfortunately, if you come out and then you just go from one slide down. we would be able to see it, but it'll just be smaller. So for example, now we can see it, but it's slightly smaller, unfortunately.
So sorry, yeah? It
No
was
worries.
working before. No, it's not. Okay. So this is the picture about what is this chronic care unit, the disease that is including. As you can see, we have transmissible infections as HIV, tuberculosis, hepatitis B and C. We have NCDs that has been usually neglected in humanitarian contexts of hypertension, diabetes, asthma, chronic bronchitis, and epilepsy. We have also mental health disorders that need pharmacological treatment as psychosis, bipolar disorder, and depression. And we include sickle cell disease that depends on the burden of the disease in the context that we are implementing a chronic care unit. Also considering always transversalities as cardiovascular complications that we know that patients with hypertension, diabetes, or HIV are at highest risk. Also nutritional screening and support, family planning, considering the specificities for the treatment and assessment for pregnant women, and also mental health and psychological support in case of needs. This integrated care that screens and treats patients for chronic diseases, including mental health and psychological support and patient support education and counseling, has been shown to improve outcomes in several studies. Oh my God, it's not working. Okay, so why in Malakal? Why we choose Malakal, this unit? So MSF Spain is working in Malakal in 2 different settings, provides medical care at 2 different secondary care level hospitals in POC, that is protection of civilian in the IPD camp and in Malakal town, and also primary care level through outreach activities. So we have seen that in these facilities, the burden and the burden of chronic disease is huge. For example, the consultations to the ER due to chronic condition are very frequently mainly due to hypertension and diabetes. More than 60% of the admission are due to chronic diseases, and we have a huge mortality in IPD due to chronic conditions. Around 70% of adults dead in 2022 were due to chronic conditions, including HIV. There is no presence of other action, and there is also the perception at community level. We perform a survey before the implementation, and this was this perception. No? Also, because it's feasible, most of the resources were already in place at the project level. We were supporting the management of chronic diseases, but partially. No? We'd have an HIV, TB, hepatitis B and C program, and we have also a mental health program, but in a siloed manner with a vertical approach and not in a holistic way. We have also taken care of patients in the ER and in the IPD with, for example, cardiovascular complications, but this patient after there was not having a proper follow-up. So there was the case, no, if we are talking about integration, that we have an HIV patient that can be followed in the consultation, but after this patient can be hospitalized because of cardiovascular complications, not having any link between the HIV TB program, and after this patient can have an impact on the well-being because of the chronic condition, depression, for example, and it's been in the mental health consultation, but with these silos, no, without any kind of holistic approach or integrated approach. So Malakal, before CCU, the patients were experiencing stigma from using service with insufficient privacy and specifically designate for one disease. No, the patient go directly to the HIV part or to the mental health specifically. That also there are 2 conditions that has higher stigma. Lack of proper follow-up, but as I say, after being discharged for chronic conditions, mainly for NCDs, and also high rates of loss to follow-up, no? Maybe because this kind of vertical approach. So chronic care can be implemented following a people-centered approach and is well accepted by staff and community to provide access to healthcare patients identified with one or more chronic diseases, hence improving the quality of life, health status, and reducing mortality related to chronic disease. So chronic care in the CCU is delivered in a cascade of prevention, a screening, that this is very important point because we were performing systematic screening for other relevant comorbidities. So we were increasing diagnosis, linkage to care, treatment initiation and retention, and also providing palliative care in case of need. The target population of the CCU is any person diagnosed with a chronic conditions according to the inclusion criteria that you can see on the right side, regardless their age of gender. So we were including children, adolescent, women of childbearing age, women in pregnancy, adults and elderly. So all were included. So this is regarding the CCU setting. We have created, organized for areas, including the waiting area. We have a nurse room, and the nurse is providing the admission, registration, is doing a screening and assessment of nutritional status. We were also assessing if there is any kind of difficulty for access to care, to reach the facility, vulnerability factors. And after the client is assessed for the CEO, well, the clinical officer or the medical doctor, doing the clinical assessment, physical examination, mental health assessment, because we are considering also the impact in the well-being. We are performing PHQ-2 and if positive PHQ-9, and also the treatment prescription. And well, both the nurse and the medical doctor or the clinical officer are providing health education. And if the patient is in need of advanced, we can say PSEC, no, like reinforced health education, for engage the patients that are lost to follow-up with adherent issues, it will go for the specific counselor, or if the patient is dealing with a mental health condition, also for the mental health counselor. So we have put in place a pharmacy inside the CCU, inside the nurse room, to facilitate also health education regarding the prescription, the drug side effects, interaction, etc. And we have provided, well, the toolkit, we have 19 protocols, one for each medical condition, and also the transversality. These protocols follow the same structure and are easy to follow for the nurse and the CEO or medical doctor, and it guides them how to follow the consultation, no? Like also a checkpoint. The CCU patient file to record, to do the registration, and also this file after is encoded in a database made in REDCap for monitoring and evaluation. Well, the clients who enter in the CCU, it can be referred for another part of the hospitals, the IPD, ER, but also for the community through the outreach activities, the DMC, and other organizational facilities to highlight the important role of the community engagement and health promotion strategy, also linking patients to the CCU, but tracing the loss to follow-up, doing home visits if allowed by the patients, and also in the next step, maybe to create some points of distribution of drugs in the community. To say only that in the CCU there are also some discharge criteria, because we are including patients with chronic conditions, but we consider as chronic because they need more than 3 months of treatment. So also we will have patients with TB and hepatitis C and mental health disorder that can be cured. And also to establish some referral system with other partners that are provided and covered service for MSF, for example, food protection, etc. So now this is how we are today. The implementation is start in the month of April and May. So from May, we have already this number of admissions in POC, no, in the IPD camp, in the protection of civilian, and in town. As you can see, mainly of our core is about HIV and TB patients, but also we have a considerable number of patients with hypertension, with epilepsy, and with asthma and chronic bronchitis. And well, for the main recommendations and the lesson learned, to say is that the chronic care units should integrate the management of chronic diseases, but after a proper assessment, and should be planned avoiding silos between disease. No, the disease should be integrated following this people-centered approach. The CCU should be planned at least 6 months prior to initiation of activities, and we need to insert the necessary human resource, the appropriate space and drug supply, and the project implication is essential to build the ownerships. As recommendations, we need a defined organigram with clear job profiles. It's recommendable to involve a team of national staff, to engage the national staff in this approach, transversal approach, at least one nurse and also the counselor, if possible a psychologist or a psychiatrist. At least we need to organize 2 or 3 rooms for clinical consultation and PSEC and mental health. A fast-track area can be planned to decrease waiting time for drug collection, but we need to think that longer refills are recommendable for stable patients, at least 3 months, to avoid this overload in the consultation. All facility staff needs to be aware of the medical protocols, and regular training should be organized. Monitoring and evaluation framework and tools should be implemented. Community engagement and health promotion strategy needs to be defined, and it's essential to alert population, encourage ownership and self-care, and decrease stigma. And also to have an exit strategy, with a proper handover and contingency plan in case of needs. So the CCU pilot project that we just started with implementation will be evaluated after 1 year of implementation. And our ambition is to prove again that chronic care can be integrated following a people-centered approach with impact in health-related quality of life. And the model should then be reprisable in other settings and adaptable to the burden of chronic conditions there. So thank you so much. Thank you mainly the team in Malakal and all the people involved in the CCU, a lot of people making this possible, advisor, reference team in Malakal. So thank you.
Thank you very much, Paula. Thank you for that
welcome.
presentation. I will introduce the next person. So in fact, it will be Caroline Aluda, who's a nurse from Kenya, who joined MSF back in 1999 as a local staff working in the country's northeastern side, and also in one of the world's largest refugee camps called Dadaab. And since 2014 has become a field coordinator with MSF, working in different countries, for instance, in Malawi, and has been able to work, now working in Cabo Delgado. So the topic will be challenges or integration into humanitarian settings, lessons learned from Cabo Delgado. So please, Caroline, over to you. Thank you.
So I'm going to share with you HIV in humanitarian setting and what lessons we have learned. So Cabo Delgado is located in the northern province, the farthest province that is in bordering Tanzania. The HIV overview in MOH is as follows. So the HIV prevalence in Mozambique, according to the Inside in 2021, was 12.5%. So, and you can see HIV prevalence, the annual incidence for those above 15 years was 0.43%. Then the incidence for women, as usual, is higher than for men. So it was 0.61%, and for the men was 0.24%. The viral load suppression, as we can see here, is below the UN AIDS 90-90 or 95-95. So you can see for both men and women is 64 and 67 and 57 respectively. So as it is seen here also, you can see the women, for example, the prevalence according to the sex. The women at in the age group of 30, between 30 and 45 years, the prevalence of HIV is higher amongst women than in men, as it's seen on this map. So you can see in Mozambique, the prevalence rate is 12.5%, and in Cabo Delgado, where we are, it is 10.5%. which is quite high. Then I will talk about viral load targets, and this is also for the males and for females. As it is shown here, you can see that the females, bull hares is females and hormones is male. So the age group between 25 years and 54 years, the viral loads are better than the other age group. So though we have not reached the viral load target of 95%, but this is the situation. So you can see Cabo Delgado here. Mozambique as a country, the prevalence is 64.7, the viral load suppression is 64.7, and in Cabo Delgado, out of the 11 provinces, we are at 42.5%, which is far below the acceptable 95%. So there's work to be done there. Then here, we're going to talk about, just a minute, diagnostic, treatment, and suppressions for both male and females. You can see the dark blue one is representing the diagnosis. So diagnosis is also far below the 95 UN/AIDS recommendation. But when it comes to treatment for both males and females, we are doing well in Cabo Delgado. So we are at 96.4%. But for the viral load suppression, which is the farthest bar, we are at 89.4%, which is still below. So putting patients into treatment and viral load suppression, we are not doing well. So now I'm going to present about hospitalization. So for both pediatrics and adults, you can see here we have the hospital and we also have the mobile clinics. So the common morbidity for admission, for hospitalization for the pediatrics is malaria, as you can see, both for adults and for children. So HIV represents 0% and tuberculosis. But down here, for HIV and tuberculosis in the mobile sites, you can see HIV represents 5% and tuberculosis 3% for children. But for adults, it represents 7% and 5% respectively. When it comes to deaths, mortalities for both adults and children, you can see clearly that mortalities related to death, that's for adults, is higher for HIV, which is 36%, and TB represents 28%. So this is in the mobile clinic, and this is the same also for this is in the hospital, and it is also the same for the mobile clinics. So this represents a number of new ARTs as well as new enrollments. So you can see in Q3 of 2023, there was an increase in the number of reinitiations and enrollment. This is because of the welcome back strategy that was put in place, and that is why we can see this increase. The increase in Q3 and Q4 of 2022 was because of the systematic screening of children and mothers for HIV, and that is why there was this increase in 2022. Then the coverage of HIV positivity in ANC. We can see sometimes we also get erratic supply of test kits. That is why there was a dip here. But with the test kits, you can see all the people presenting in the ANC with unknown HIV status are tested for HIV. So this improved, but before this time we were below 95. So it improved in Q3 and Q4 of 2023. So viral load. So here we can see that comparing 2021 and 2023, the viral load sample collection in 2023 increased quite a lot because we had 378 samples collected as compared in 2022 where we had 120 samples. In 2023, out of the 378, 105 were undetectable. And in 2022, only had 29. Yeah, so this is the viral load. But then we can see on this table that we had problems of results coming in because viral load sample collections are collected, and this can be seen in the blue bar. But then for the results that are not coming in, especially for April and May, so we had some problems with the processing of the viral loads at the provincial level. So CD4 follow-up in the mobile clinics. So we can see here clearly that CD4 has improved, because for those for CD4s less than 200, we had 21%. And for CD4 that were greater than 200, we had 79%. Then for example, in 2023, we had 443 CD4 samples collected, as compared to 2022, where we had 133 CD4 samples collected. So the table here represents TB screening in 2023. It is clear that in 2023, we had the Gene Expert machine, whereby you can see 875 sputums were processed on the Gene Expert platform, as compared with 2022, where we had TB smears. So in 2022, we had 182 smears carried out in the hospital, and we only had 144 Gene Experts carried out. And this is because the samples were taken to the province. But now we have a Gene Expert in the district, and that is why there's this improvement. So what are the challenges that we are facing in Cabo Delgado post-violence? So HIV care was not prioritized post-violence. As we all know, there are other priorities, especially from the first presentation where we saw malaria was the highest morbidity and mortality, so HIV was not considered. Then there was lack of access to HIV and TB data, leading to duplication of individual-based data. And therefore it increased, all positive cases were considered as new, yet there were not new cases. Also, PMTCT is a problem, which implies that all infants were not initiated on prophylaxis, the very rapid prophylaxis. We also face a problem with non-availability of TB-LAM and TB-CRAG to be able to rapidly diagnose tuberculosis. Management of patients with advanced HIV is also lacking in the district. Centralization of HIV and TB activities was also contributed heavily to the HIV and TB program. And this also led to no proper follow-up. The migration of patients up and down due to insecurity also played a role in the lack of follow-up of patients. The other problem is lack of disclosure between partners upon testing positive. So there's no update of patient milestone in database, because all these databases were not being followed up from 2020 up to 2023. This November, we started to enter the patient's milestone in the database, in the Open MRS database, because Ariel Foundation was doing the follow-up. So there is also inadequate supply of HIV commodities like viral load cartridges, and also delays in the transportation of viral load and CD4. So this photo shows what conflict can be in terms of following HIV patients. So there's scattered patients and few patients coming in and out. So this is tracing of patients who disengaged from treatment. So what have we put in place? We have put an implementation of the welcome back strategy to be able to reinitiate patients back into treatment. So this is one of the achievements that has been put in the district, to be able to carry out viral load samples on the Gene Expert Gene Expert platform, which has improved the turnaround time for the results. Training of MOH lab technician also took place. So this has really helped has helped the turnaround time of the samples. Okay, so this is the situation of the HIV in the district. So I talked about the open MRS reporting system in Cabo Delgado. As seen here, patients that had been enrolled before 2022 were 5,532. Out of this, 186 had been transferred out. So, which means we had 5,347 patients in the system. However, of these patients, those who are active at the moment that we can follow in the open MRS is 153. Those who are reported dead and stopped treatment are 521. So unknown are 467. So there's a lot to be done. So I will go to the other project, which is Macomia, which is a partner project in Cabo Delgado. So you can see they're also trying to bring patients back into treatment. So you can see the new cases are at 107. Those who have been initiated were 104. Retrieved were 8, and they have a total of 227 patients on treatment. So what are some of the challenges that they're facing? So there's chronic rupture of prophylaxis, is nevirapine prophylaxis in the district for the children. So active, there was no, all HIV activities are centered to one person, making it difficult to follow the program. Lack of training of the staff for the tracing of the patients who are disengaged from treatment. And also there's no local lab that is functional for lab analysis. So most of the lab samples are taken to Pemba. There's also no open MRS for data monitoring. So the other challenges include all CD4 and viral loads are transported to Pemba. Patients in the hard-to-reach areas, it's difficult for them to access treatment because of insecurity. We have quite a number of missed appointments due to high mobility, and which is caused by insecurity. So there's a lot of advocacy that has been started and also has to continue. So this has been done with local stakeholders, the HIV unit and tuberculosis unit, to be able to have HIV and TB commodities. So the other, advanced advocacy also is taking place to enhance closer contact with the largest donors who are Global Fund and PEPFAR, the World Bank and UN agencies, to be able to increase TB, HIV screening, and malaria. There's ongoing mapping of local donors to ensure we have a proper allocation of resources to the MOH. And this is also national and local NGOs. So conducting health surveillance at national level is also ongoing. So we are also engaging youths in schools in the prevention of new HIV cases. So this is the end of my slide.
Thank you very much, Caroline. Thank you very much, Caroline. So the persons who have made their presentation so far, I will ask questions according and try to direct them to who I think is appropriate to answer them. There's one first question, I think I'll answer that myself. There was a question around what exactly does person-centeredness or patient-centeredness mean in as far as HIV care is concerned. Well, I think it's in the definition, it's in the word, or it's in the expression itself, because the idea is to center all of our interventions around the constraints that the patients have. So the question is, looking at Jihane's presentation, looking at Paula's presentation, we talk about patients who are able to access their treatments depending on their own convenience. So in terms of having a differentiated model of care, what are the constraints that they face? Is it transport? Is it distance? Is it adapting clinics like was being done in Malakal to in fact reduce stigma and of course the barriers that can be seen when people are trying to access care? So the question is in fact how to adapt essentially the services that we provide as care providers to the patients and not the other way around, which tends to be the case where people will, in fact, it's the patient who has to adapt or change themselves to fit in to the way the health facilities are functioning. Now, if I will start the questions, so one question I will ask, I think this is going to Jihane. So, hello, very interesting presentation. How did you measure the satisfaction, experience, patient satisfaction when you did the DSDM in the different studies? So that's, I think, a question for Jihane. And then a second question, I think, is the same to Jihane as well. Was there a difference in satisfaction between women and men? And also, is there a difference in terms of ages of the different respondents? Thank you, Jihane.
Merci, Chris. Je vais répondre en français. Merci
Thank
pour
you,
vos...
Chris. So I will answer in French, and I will also include the question from Douglas that may be compiled with the two previous ones. We measured the satisfaction level in two different ways. In Uganda and Kasese, we work with an anthropologist who measured the perception, the satisfaction, as well as the challenges through individual interviews as well as group interviews, so a qualitative survey really. In Goma with Dr. Frank, we developed a questionnaire that was adapted from other questionnaires about their personal satisfaction, and we didn't go through interviews. So it was more of a quantitative questionnaire where people were responding from not satisfied at all to very satisfied. Is there a difference in satisfaction between men and women and according to the age group? We didn't measure the retention in care or the observance, but the adherence, but we observed that the time of treatment, so the time from the contamination by HIV, the longer the treatment, the more retention. So patients who had started the treatment, for example, 2 years ago, were more likely to get lost than the ones who started a longer time ago. And we also noted that the younger generation were more likely to be lost, but this was also correlated to the duration of the treatment. So as for the third question, we had a few percentages of people who showed dissatisfaction. I will not mention all the reasons, but there were mainly personal issues with mainly the interaction with the rest of the group.
Integrate HIV and non-communicable disease care in the same context to ensure that patients are seen at one point and by one clinician on the same day. And then the second question to you, Paula, as well. What did you do in Malakal to reduce waiting times in your clinics? Please go ahead, Paula.
Okay, thank you for the question. So the first one was related to the people-centered approach in HIV, if I well understood.
Yes. How do you organize your clinics such that one clinician can see a non-communicable disease, can see HIV, can see all different kinds of pathologies, but within the same clinic environment?
Yeah. So for that we create a training planning for the clinician, and they have also the toolkit that guide with all the conditions. If we are talking in terms of capacity, learning capacity, it's true that we need to strong the clinical skills for the clinician. But as we have seen, it is possible because we are following. There are most of the patients, they are stable patients. It's like primary healthcare, we can say. So there are in the protocols very specific information regarding how to follow the consultation. And also regarding the waiting times and the capacity of if one consultation, how can we perform all the follow-up for the several diseases, to say that is the same thing. No, if the patient is an unstable patient, we will follow the patient for 3 months. So if we are able to do this consultation, this follow-up, a proper follow-up assessment, assessing of the needs of the patient, and providing treatment for 3 months, at the end, there is not like this overload in the consultation. So one of the main points is to have the capacity to provide the next follow-up in 3 months for the stable patients, to increase the capacity of the staff, and also to have these tools to support the consultation. And regarding the waiting times, the idea is to have the agenda or the system of the appointments that avoid that all the patients come at the same time of the consultation. And also there is a team with 3 people. No, it's not only one consultant. It's the nurse, it's the CEO and the medical doctor, and it's also the counselor. And also the HP team that should be trying to organize the flow of the patient and try to reduce waiting times. One of the key points is to have also for distribution of drugs, a fast track area of this capacity to provide drugs. And with that, we hope that we can be able to manage the waiting times. But for sure to say that if we want to do a proper assessment and a proper consultation, and we are talking about people-centered approach, that we need to see the individual's need. No, we are doing mental health screening, nutritional screening. We are screening for all the comorbidities. We are taking vital signs. So all of this is time, but it's time that at the end we need to do a proper assessment. No, so we need to balance the waiting times, what we need to do with the patient in a proper consultation.
Thank you very much, Paula. And 2 questions for Caroline. So, question from Mueda Cabo Delgado. In Macomia and in Palma, what were the strategies implemented to recover lost to follow-up patients? Because you had mentioned in your presentation that there were some patients who were lost to follow-up. And then a second question, I think, for Palma as well. What about HIV interventions for victims of sexual violence? So over to you, Caroline.
So I will answer the first one. So what are the strategies that we came up with to follow the patients? So we came up with the welcome back strategy. So with this one, we go to we try and trace the patient from their communities. We go door to door and we trace the patients. And then the other strategy that we used is the peer. The peers, we are working with peers. This is activists. These are people living with HIV and AIDS, and are acceptable in the community by the peers. So the patients are able to say, the patients are able to identify with their peers and come back into and engage back into treatment. Then you talked about sexual violence. Just come again with the question of sexual violence.
In essence, the question was, do you have an intervention in Palma for victims of sexual violence as far as HIV is concerned?
Yes, we do have a 72 hours project that that we have adapted for the sexual violence. However, what I would say is that we are not getting so many patients who have gone through sexual violence, because we are like 2 or 3 years post-violence. So the sexual violences that took place in 2022 passed the 72 hours medical recommendation. So what we are doing much now is psychological care post-violence. So we are taking care of we are giving the psychosocial and psychological support for those who went through the sexual violence trauma. So the cases are not quite a lot, because most of the patients who were being abducted and went away were being carried away with the insurgents. So most of the patients are not, few patients have been raped, so psychosocial support is being taken care of. So that is what we are doing.
Thank you very much for that response.
Can I just add quickly to support Caroline on that? I think in the beginning also want just to show that the Cabo Delgado is our 2 projects. The security context is very different, volatile from Macomia and Palma. So where under emergency. So we are trying to be out for the emergency. So there was some priority on top. And then now during the hour, looking for how really to integrate it, some package on the HIV and TB. So we, under emergency, was very complicated to do everything and follow everything. Was many life-saving. But this is the packet, and then you see the difference on the context. Like I said, there are many more moving on Palma side because we are talking about the context a bit more stable now compared to Macomia. And nevertheless, yes, we do trying to do duplicated what's happening to Palma on the good things to be happen also to Macomia. We plan on the sexual violence, the treatment center place, and then they've been tracked when needed. Except on that, also we like also to put the strategy also on sexual workers to be attracted and then follow up on the HIV, how their status. So just to add what Caroline says already. Over.
Thank you very much. I will ask maybe one additional question for Caroline and the team in Cabo Delgado. So in fact, there was a question that was put here. What is a profile, or have you noticed that there's a profile that is recurrent in people who are lost to follow-up? And then the second question is, do you have a differentiated model of care that you use, in fact, to adapt to the context that you mentioned when there is violence or when there's movement of populations? Thank you.
Yes, I will answer the second question to say that the model that was used in Cabo Delgado was, for example, it was the mobile clinic. So as MSF, we have been out there going with ARVs in the mobile clinic to provide the ARVs. There was no CAG. There is no CAG, and the activists, the community health workers had not been trained to be able to transport the medication to the communities. So as MSF, we have been there during the hot period to take the medication to the patients. So no CAGs, all the CAGs collapsed. So we have to rebuild the CAG community ART groups. The community health workers had not been trained, so they're not able to distribute the medication. So a centralized system was adapted by the district, which was very difficult. So the patients decided to go for traditional medicine because they were not able to come to Palma District Hospital for treatment because of the distance and because of insecurity.
Okay, thank you very much. I think we will, we've taken a bit of time. I think we will give also a space to, people who have been living with HIV. So I will introduce the next person who is going to, again, it's going to be more of a roundtable discussion. I'll ask her a few questions and she will respond, is Patricia Acero Ochieng, who is the president of the International Community of Women Living with HIV in Kenya. She is, Patricia is an HIV advocate and has lived with the disease since her diagnosis in 1990. And she's the chairperson of this International Community of Women Living with HIV in Kenya. She has also coordinated Dandora Community AIDS Support and other associations such as DACASA. And she has over 30 experience, I would say even very personal experience with HIV. So welcome, Patricia. Are you there?
I'm here, thank you.
Perfect. So I will just ask you a few questions and please feel free to respond. So the first one I will ask is, what are the major developments that you have seen in terms of care in Eastern Africa, where you're from? I mean, you have over 30 years of experience. What have you seen that has changed or that has improved in the last 30 years?
Thank you so much, and hello to Carolina. I don't even know whether she remembers me. A lot has changed. One is the mode of testing, that you don't have to take time to get to know your results, that we have the instant kits that I can be tested now and within minutes, I'll know my status. That one is one improvement. Two, that has changed is the fact that nowadays we have treatment guidelines. Countries within East Africa came up with the national AIDS support control units, which when we started working with MSF, they were not there. So that means countries have guidelines and people will know when to take first line and when to take second line and sit down and talk about the third line. What has also changed is the mode of monitoring. You know, when we started taking treatment, the only monitoring we had was CD4. And everybody was so scared about their CD4 not improving. But now that we have a standard way of looking at monitoring, which is the viral load, that has also improved care. The other thing that has improved is the reduction of mortality. So when I started working for MSF or taking antiretroviral medication in Kenya, we were losing like 700 people a day. But now it's down. So that is something that also has quietly improved. The other thing that has improved also the training. There's been a lot of training for clinicians, for nurses, for counselors, and it's like treatment is standardized. The training has been able to improve the kind of care that people are given. The other component is the diagnostics. We realized that people living with HIV were dying of TB in their numbers. But as I heard even Caroline talking about the gene expert, the things that we were quoting about, that it's possible now to pick TB in people living with HIV with the gene expert. It's possible also to pick with the TB lamb. Those were things that were never there. So that has also kind of improved the type of life that we have.
That's great to hear.
The cocktail, where we were like, you'd hold medicine in your hands and you think it's, in Kenya we call them jugu, the groundnuts. You think like you want to eat groundnuts and you have like 6, 8 or 9 pills in your hand. But now that we have the fixed dose combination, you're taking 1 pill instead of 3 or 6. So that has also come a long way to help us with things. The other component is the efficacy of the medications that we have now. We were so scared of the side effects. You remember the stuff with the lipodystrophy that we were getting from all the other medication. But now the efficacy, the side effects have gone down and you don't need to take so much. Like if you take DTG, you know that you're not taking a favirenz of 600 milligrams, you're taking DTG 50. So
that's excellent.
That is something that I would say that has improved.
I will ask you other questions. So in fact, you've listed quite a number of things that have improved. And I think these are also all running into the patient-centered care, because as you mentioned, the pill burden in, taking, a bag of or a handful of pills with all these different side effects, etc. But the second question I would ask you, so what do you think we could improve? Because, I mean, it's good to hear these improvements, but it's always also good to find out what are the things that you're hearing back from other peers, and then that what we could try to work on for the future.
What we should improve is the kind of care that we have decentralized. Decentralization is good, but what have we decentralized? We've decentralized care to the health facility that is run by a nurse. I heard Caroline talking about that. But does the nurse have all it takes to be able to dispense these drugs to a person who has NCDs, who is living with other conditions as well? So as we decentralize, let us decentralize quality care to the people, yes. And also let's make it possible for the decentralized units to also have labs, so that we are not thinking about having parallel systems of carrying these samples to different places, and then the samples are being brought back that when they arrived in that place, now they can no longer be used. The other component that we need to look upon is integration. Instead of a mother having parallel clinics, that she's going for her own clinic, and then she's coming back, she's taking the baby, then she's coming back for family planning, then she has other things to come back to. Integration of services, that will be vital. The other thing we need to look at is also commodity security. I heard Caro talk briefly about the erratic supply of testing kits. Commodities are the same. You might want to have everything integrated, but you don't have the commodities. So it's useless to have a clinician sitting there saying, take this, take that, and they don't have access to the commodities. So I think that is something that we need to to be able to bring to fore.
That's
and
great.
The last and not least is the disciplines that we have in the house. When you're talking about psychosocial support, you don't have counselors in place. When you're talking about social support, we have social workers in place. I remember when MSF set up a clinic in Bagadi. Those are things that were taken into consideration. We had doctors, we had nurses, we had clinicians, we had lab techs, we had pharmacists, we had counselors. So it was everything around one roof. You'll just need to refer to room 3 or to room 4 or to which room, because those people were around. So that is when you're talking about holistic care, I think that is what you should be looking at.
Which brings me to the question, my last question for you is, do you believe or do you see that in fact all of this is as holistic as it could be? Because at the end of the day, and that's one of the key points of today's webinar, is that the focus is the patient. The focus is you as an individual, Patricia, and it's how do we make sure that we come around and those things that are required by the different patients, that they are different, that they're met. So how do you think we could also improve on that?
As you all know, HIV is still a complex disease, and which impacts the different facets of an individual's life. So when you're talking about holistic care, you should be able to take care of those different components of the facets of the individual. So when you take care of one facet, then you think you've taken care of it. That is not holistic. You should take care of that person as a whole. I remember going to Aga Khan and the doctor saying, can you send the other patients to the other room? Patricia is 10 patients in one. Because I carry quite a number of things. High blood pressure, I have DVT, blood is clotting, I have a problem with my lungs that the colleague you're talking about, I have a problem with my heart. So if I walk into a room, I need to be able to meet a clinician who's well trained to be able to tackle that. Then within that facility, my other needs are also taken care of. Like my psychosocial need is taken care of. I have a problem, I need somebody to talk to. I need a lab works. I need to have an X-ray. So I need to be treated holistically. And I think that will also improve retention, and that will improve adherence. Because when you are taken care of, everything is taken care of. Why should you not take your medication?
Perfect. I mean, we had actually a second person who was supposed to be with us, Bienvenu Gazalima. I don't know if he's been able to connect. He's also a patient, but from a different context. So also give us a little bit of his own experience. I don't know, Celine, if he's been able to connect. Bienvenu.
Sorry, no, I think he has some trouble with his connection. So sorry, okay. He couldn't join us. Sorry.
So unfortunately, Bienvenu was not able to connect. I think we will continue with our discussion. So last question, I think I will ask this to Patricia as well. What is the importance of a patient-centered approach, do you think? I mean, how important do you think it is for you? I see that also Caroline has raised her hand. So after Patricia, I'll give the floor to Caroline.
When we have a patient-centered approach, your patient will be able to own their own treatment. The clinician, the nurses, and that will not have to struggle so much. Your patient is well taken care of, so they'll own their treatment. It will give you an easy time, and it will also make your patient more independent, and you'll be in a partnership. It's not like you're giving directives, you're working with the person. So that's the difference.
That's great. So Caroline, and then I will move on to Cleo. Caroline, I can't hear you. Unless if your hand was not raised.
Unmuted. I have unmuted.
Yes, please go ahead.
The thing is, I wanted to ask Patricia a question in relation to empowerment of people living with HIV and AIDS. So what has her organization done to be able to demystify stigma amongst people living with HIV and AIDS?
Thank you so much, Caroline. From where I sit, one thing that helped with the demystifying stigma is empowerment. And the empowerment only starts with treatment literacy. You know, a person getting to understand that HIV is not about what they're told in the community, because people are told different things at different places, given where they're living. So one important thing that has helped us to demystify stigma, those treatment literacy, a patient getting to understand the science of HIV, how it is transmitted, and what they can be able to do, so that they're able to defend themselves at that level. The other thing that is now also helping us to demystify is you is equal to you. Yeah, I'm undetectable, I can no longer transmit it. The other component is also the policies that are in place that we can be able to use even to take people to court who are stigmatizing us. I'm sorry to say that people living with HIV in Kenya took MSF before, and MSF needs to take into account the human rights of patients. Caro, you are in a new country. I think the area around the rights of your patient is very vital. Here in Kenya, MSF was taken to court that they coerced women to be sterilized so that they could be given men. So those are some of the areas that we need to look at. So issues around rights. Your patient needs to know their rights, and they know they can be able to claim those rights. So those are some of the areas that help to fight stigma.
Thank you very much. Thank you very much, Patricia. And I'll now introduce Cleo, just a second. So she's a flying patient and community support advisor with the South African Regional Health Promotion Focal Unit, has specialized or is a specialist in clinical psychology in France, joined MSF Greece for her first mission in primary healthcare projects focusing on migrants and refugees. And for more than 15 years has been volunteering and working in many different places in Africa and Southeast Asia, focusing on, mostly on psychosocial support for HIV and TB patients. So welcome, Cleo. I will ask you a few questions. I think you've listened to what the people who have made presentations have done so far, and including, a patient herself, who has given us a feedback as to what things are important, for patients themselves. So first question to you is the integration of these approaches at all levels and by all staff working with people living with HIV. We've seen a little bit of this in Malakal, trying to have clinics that kind of are integrated or putting multidisciplinary clinics in the same space to limit, as Patricia said, having to go back and forth. So how have you seen that, and how would you like to talk about this for HIV care?
Yeah, thank you, Christopher, and hello, everyone. Thanks also to the previous presenters for bringing up beautifully all that is required basically for the HIV care in the programs around the world that we have. Christopher, I just want to highlight one point, and I will take it from what Patricia was talking about earlier and bring it back to the integration and the different staff at different levels, not only at health facility, but also at community level. I do believe that the key word here is really to try and see what is the quality of the relationship between the people living with HIV and the healthcare providers. Yeah, whether these healthcare providers are doctors, clinicians, nurses, PSEC staff, HPs, counselors, or community healthcare workers, it doesn't matter. Each one of us may be engaging at different points in time and at different settings with a person living with a chronic disease, such as HIV. But what is really the key component, how much of this relationship, how much do we see the people as people, first of all, rather than patients, yeah? And how much focus will we put on building this partnership where we, healthcare providers, let me put it that way, we may have an expertise on diagnosing timely, on prescribing treatments, taking care in terms of medical, psychosocial support. But at the same time, we need to be acknowledging that the best person, the best expert actually in taking care of themselves are the people who live with a chronic condition, right? So I wonder how much time do we really put during a consultation or whatever dialogue we have with a patient on the quality of this communication. How open are we really to listen and assess the real needs of the people and try to adapt what are the medical requirements, let me put it that way, to the context, to the personal needs that each person has when is coming in a HIV chronic care program. Yeah. For me, the key point here is really like talking, dialoguing, with the people together, trying to find what are their needs, and most importantly, how together can plan an individualized care plan based on these needs, based on possible constraints, and also based on the strengths that each individual has on really like following treatment adherence requirements, retaining care, etc., etc. Does it make sense?
Yes, it does. In fact, you've answered, two of the questions that I had, because, one of them was going back to the fundamental question of what is the importance of patient-centered approaches. And you've said that, you answered that question without even being asked it by saying, well, in fact, the person who can actually bring more to the table is the person who actually knows how to take care of their own body. So if we do not have that space to dialogue and to learn from from the patients themselves, or from these people, in fact, as you say, that these are individuals with different components, as Patricia has rightly said, that I'm not just HIV, I'm not just my TB, I'm not just hypertension, I'm a human being that has other components of life as well. And how do those things impact specifically but the disease, but also more broadly how we are living our own lives as well. And then I would ask also the question regarding how do we, in that case then, more practically speaking, how can we take the patient's expectations, the patient's needs, the patient's desires, so to speak, and apply them? And how would we practically do that in terms of taking that dialogue now and translating that into the reality of either adapting our own interventions to meet those patients' needs?
Okay, so very good question. I mean, besides like the individualized care plan that I was just talking about, that is really discussed between the healthcare provider and the individual, and making a plan about how they can take into treatment, how they can be coming in a health facility, how they can be doing their lab tests, etc. So besides that part, I think it's very important that we organize every now and then. And I think like the first presenter mentioned also about like the patient satisfaction surveys, or, like we can be having like different types of assessments. And I'm sure that more or less in every project there are HPs, or maybe there are counselors, psych staff, that they can be really discussing with the patients. And then not only that, but like assessing and discussing with them about what is the best way to put in practice, what the people need. Of course, we listen, and we plan together. I think that's the key word, because it's very easy to say like, okay, we saw this, that need, we did these surveys, blah, blah, blah. But then, okay, what do we do after? As you say, we can propose A, B, C from our side. No, we need to be discussing together, again, with the community, and the communities of PL-HIV people about, okay, what is the best way? What can we put practically, on the table and put it in a program so that we can deliver the best way possible, what needs to be delivered.
That's really an excellent response. And linked to that, I was, not to forget that this webinar is co-hosted between the HIV Working Group and Epicentre. We do have researchers actually who are connected online. So I will ask one question to Patricia. If you had a wish list, basically, of where are the areas that you feel that we could improve by doing more research, where would you think that is? And that's a question I would ask. If Patricia, I don't know if you're still connected.
Can you come again?
Yeah, so the question was, if you had a wish list of, where you think research, we could continue to do research to try to improve things for people living with HIV, where would you, list, or where would you propose?
One area that would propose is the women aging with HIV, because there are a number of things that women are experiencing now. We don't know whether it's antiretroviral medicine. We don't know whether it's just the virus itself. So that's an area that I would want research to concentrate on.
Okay.
The other area would be TB in pregnancy.
TB in pregnancy. Okay. So for the first question, you mentioned women living with HIV. So is it older? So when you mentioned getting older, are there certain symptoms that you believe, or certain changes that women are experiencing that you think, in fact, we should try to understand more?
Yes. Areas around the DVT, the aging itself, the aging process. Women are aging so fast. The people are age, and the ones who are taking antiretroviral are there's quite a difference.
Okay.
Mental issues. Women are getting so depressed. Those are areas that I think that would need research.
Okay, that's well noted. That's well noted. I think there were a few questions that came in. I think some of them are looking similar. I think this could be answered by any of the presenters. So basically, they're talking about the differentiated models of care. So talking about the CAGs, so which is the community ART groups, so the CCLADs, etc. How do you adapt some of these to specific contexts? So I've seen someone who mentioned for migrants, some people who are mobile. So we have people who are mobile. We have places where there is conflict. And so, of course, could be displacement of people. And of course, there's that insecurity. So how do you think we could, in fact, adapt some of these differentiated models of care to cater to patients? I know that Caroline had mentioned mobile clinics, so that could be one way of doing it. But I don't know if any of the responders would want to talk about that.
This Patricia, can I go?
Yeah, please go ahead.
One thing that maybe would depend on is the digital platforms, that people would have unique identifiers, and they would be able to pick their medication in any facilities across the countries where they were, or across the areas where they were, just by giving their unique identifiers. That is one. Two, the multi-month scripting, where I have my 6 months medication with me. That also works. And the last but not least is working closely with the people living with HIV themselves and finding out what can work for them, not just deciding for them. We've seen centers where the clinician decides, or the nurses or the peer educators, from number 1 to 15, you are in a community ART group, not knowing where these people are coming from. When I worked in Baghdad, we had people who were coming from Turkana, others coming from Nakuru, others coming from Kisumu, all the way to Baghdad, and that was Nairobi. Others are coming from 10 kilometers from the facility, others are coming 400 kilometers from the facility, others are coming 200 kilometers. You cannot group them all together. It has to come from the clients themselves to decide, we are 10 and we want to be in a CAG. We are 10, we want to be in a adherence club within the hospital. I want the fast track. What you do best is to give them what is available. What are the DSD models within the specific facility, and let them choose. So back to you, Chris.
Excellent response, Patricia. In fact, I have a bit of experience with the DSDM models that we've actually rolled out in Uganda and Congo. And I will always say this to my teams, that I found it quite interesting that, in fact, almost 40% in one of our sites preferred actually the health facility-based, the classic model. And then it was interesting to see that for some of them, coming out every 3 months to meet it's a community of people who share more or less the same issues, and so they come together. You see them, they discuss because they don't live in the same villages or in the same community. So for some of them, they prefer actually that displacement, to come and at least see, in quote, see people who we share the same concerns with, and to discuss. And then, of course, there are others who say, look, I'm quite busy, I'm a fisherman, or I'm a business person, I travel a lot, and I would prefer to have a CAG or someone to pick up my pills because I'm not available. So I think, as you mentioned, Patricia, I think that's the most important thing, is the people who are concerned, what are their own constraints, what are their own, ideas, so to speak, how can they tell us in which ways we can meet. I can say we can meet halfway to make sure that I like that word partnership, is to partner together with the patients and make sure that everybody is, in fact, to say this as well as a manager myself, is it makes our systems a lot more efficient when the people who are using those systems, in fact, tell us where are the bottlenecks and what are the things that works or doesn't work for them. So any last comments? I think we've gone around the presentations. We've had, I think, some excellent discussions. I don't know if there's any last comments or last remarks. Please raise your hand and I will let you go. Otherwise, let me see. Caroline, is your hand raised, or it's an old one?
An old one.
It's an old one. Okay. Yeah, so I just a reminder, I think it was put in the comments that this is the first in a series of 3 webinars. I think the topics might be slightly different, but at the end of the day, the take-home messages are that the patient is the center of all our interventions. The idea is not to create the perfect clinic that is empty or that is not being utilized correctly. The reality is that we do not want to create more constraints and hurdles for patients to be able to access care. The idea being that we want to have a system that is user-friendly, that is efficient, I think both for the patients concerned and also for the care providers, and also to be able to optimize resources. I think that everybody is aware of cost of living crisis everywhere in the world, and all institutions, including MSF, is having to go through all kinds of internal gymnastics to optimize its resources. So the reality is that if we can find a model that is matching everybody's needs, which means the patients are happy, and also the care providers and the health facilities and health structures or health systems involved are also adapting to that, then I think everybody will also benefit. So in the absence, I don't see any hands raised from the people who have the possibility to raise their hands. Cleo, if you can.
Yes, I just wanted to say one more thing, if I may, because we are discussing about the differentiated care and the service delivery for stable patients. But let's not forget that maybe the people who are most in need are also those who struggle and who have challenges and difficulties. So it would be interesting to hear from them, like what differentiated care we may offer for the people who are struggling. Yeah, that was one point that I wanted to say, and maybe that could be another, I don't know, research or like a study, that perhaps we need to invest more.
You're totally right. And I think Jihane can give you more information about that, but we actually, I would say in a nutshell that the differentiated models of care are sometimes they exclude people, in fact, who sometimes need it the most. So because the criteria for inclusion is stability.
Yes.
And we try to go against that in Uganda, for example, where we discussed with the authorities and said, no, we would like to create an exception that even for patients who are unstable, for what we talk about instability is clinical instability, that these persons should have the option to choose which of the models of care is best adapted to them, because it's basically a no-brainer. If the person is not taking their meds because they're not able to come to the clinic more regularly, well, then I hope we should be able to give them options to facilitate their taking of of their medication. So, I mean, I think you hit the nail on the head.
Absolutely.
It is that I would say 5% or 10% of people who they have social issues at home. There's issues, economic problems, money issues to get transport or to be able to come. If they have other health concerns and have mobility issues or disability on top of the fact that they're HIV positive, it just makes everything really complicated. And then I think you're completely right in saying that category of individuals are the ones that are sometimes being left behind. So how do we come together to try to, one, make it more visible, make them to say, look, where are these individuals? And then how do we interface, and try to propose solutions and listen to them as well. So thank you very, very much. In the end of the day, I thought we were going a little bit over time, but in fact, finally it was not too bad. I would like to say thank you very much for all the presenters. Thank you very much for taking the time to prepare your presentations. Thank you to the teams behind those different projects. So in Malakal, Cabo Delgado, in Goma, and also in Kasese in Uganda. Thank you very much as well to Cleo and also to Patricia, who have given their insight and personal experiences as well. Thank you very much to Celine and etc., who has worked hard, long and hard to organize all of this, and also to the HIV working group. So thank you very much for joining this and all the participants online. Thank you for joining this webinar today, and I sincerely hope that more of you will be able to join for the second and third one in the series as well. Thank you very much.